emergency of international concern, African countries have scaled up their response measures and made progress to curb the spread of the virus. So says the WHO. Coordinated action between governments, WHO, Africa Center for Disease Control and Prevention, communities and partners has helped strengthen disease surveillance, expand laboratory testing, roll out vaccination, and improve treatment and care of people with Mpox. To speak a little bit more about this, we're joined now by the World Health Organization Afro's Dr. Patrick Otim, who is the WHO Afro Regional Manager. A very good evening to you, Dr. Otim, and thank you so much for taking the time to speak to us.
Thank you very much, and it's always a pleasure to speak to you and the viewers.
Dr. Otim, let's just track back the past 12 months. What has happened? What have we been able to do systemically to arrest the spread of the disease?
Thank you very much. So yes, today we were marking 1 year since Mpox was declared a public health emergency of international concern. This, as you will recall, was triggered by an upsurge in cases last year towards the mid of July coming to August, particularly from DRC, but spreading to the neighboring countries of Burundi, Uganda, and Rwanda. And this was also due to a new variant of the clade 1, which is clade 1b, and then that's precipitated the declaration of a public health of international concern. And immediately, WHO, working together with the partners, we did activate both the global and continental response. So at the global level, we had global response, strategic preparedness and response plan. We had mechanisms activated to help us access vaccines, that is the Mpox vaccine access and allocation mechanism, which then translated at the continental level to the first ever joint response plan between WHO and Africa CDC and 24 other partners, which we have been implementing through a joint continental incident management support team that is co-led between us in WHO and our colleagues in Africa CDC. Through that mechanism, we've been able to achieve a number of things. One, in terms of surveillance, enabling the member states to be able to identify and confirm Mpox cases. So we've trained healthcare workers to be able to detect. We've supported laboratories across the countries. Now all the countries, actually from last year, all the countries are able to test and confirm for Mpox. Our focus now has been taking the tests lower, the decentralization to be closer to the communities. In terms of case management, supporting the establishment of treatment centers where people can receive care early enough to be able to prevent severe disease and death, and then the rollout of vaccination. So through this mechanism, we've been able to advocate and have at least secured 3 million doses of vaccines. So far already, 7 countries have been able to roll out up to close to 1 million doses of vaccination. That is really targeted vaccination, looking at the priority risk groups in the countries that are affected. So significant progress made, and we have seen in the last 6 weeks sustained decline in the number of confirmed cases, at least declining by 34% across board. We are cautiously optimistic that this decline will be sustained going forward.
So I know you mentioned countries like Sierra Leone, like the Democratic Republic of Congo, where there has been a decline, but are there countries that are still priority areas in terms of case burden? And what are your concerns there in bringing down the levels of Mpox infection?
Thank you. So from last year, we've had 28 countries being affected. Out of these 28, so far we have 22 countries that we still classify to be in active transmission. Active transmission means that they have at least reported 1 case in the last 6 weeks. But when we look at those, when you try to look at the burden in terms of the case numbers, you will find that the top 5 will really be DRC, Sierra Leone, Uganda, Guinea, Liberia, and Burundi. That is looking not cumulatively from last year, but really the cases that have been reported in the last 6 weeks. Of course, Burundi has really had significant progress. I was checking with them yesterday. You will see that like they had only 2 active cases in hospitalized. So they have really done a good job. So now in these 5 countries that I've listed, DRC has been the hotspot. Sierra Leone, which came towards the end of April, and they have really made significant progress. They have had sustained decline over the last 4 weeks as well, though their case numbers are still high, but they have really been able to get on top of the transmission. And then you have Uganda, which is also on decline, though the number of cases are still high. The number of districts affected has significantly reduced as well in Uganda. So there are 3 things that we are worried about. For us, we look at all these countries that have community transmission, which is 15 out of these 22, as countries where the risk for amplification of transmission is still there because we have active cases. The second one is, of course, we have very limited doses of vaccines available. So we are worried about any increased transmission, then we may not have sufficient doses to go by to be able to target the priority groups in those areas. And then lastly also is we are operating a very resource constrained setting, because as you're aware, in terms of the reduction in funding, so we prefer that we are able to respond and contain outbreak when they're still small, because then if they become bigger, it will become quite challenging to master the resources that are required to contain a bigger outbreak.
And I want to have a look at the data that you are relying on to check the rate of transmission. You mentioned the Democratic Republic of Congo, you mentioned Uganda as well. Now, these 2 countries, I understand that they've cut back on testing. So in terms of your surveillance effort, is that not problematic? Does it give you an accurate picture of, particularly when you talk about active Mpox transmission rates?
Yes, so the sensitivity of our surveillance system is a very top priority for us, because if the surveillance system is not able to pick cases in the community, then we miss chains of transmission and it can go undetected and become much bigger. So we've been working with the countries to ensure that we maintain a surveillance system that is sensitive. There are different approaches being taken. One of the issues is integration, because Mpox cannot stand alone. The response and the surveillance cannot stand alone. It has to be part of the overall surveillance system. And most of the countries have included Mpox as a notifiable priority disease condition in the country, and therefore it means that the regular surveillance system is able to pick through the health facilities if there is any cases that could have been missed or they present. And most of the countries have also implemented community-based surveillance, that you have community healthcare workers that can report clusters or syndromes that look like Mpox. But also we have rolled out what we call the EIOS, the epidemic intelligence from open sources. So we are able to scan, even if the normal surveillance system is not able to pick, we are able to scan social media, different posts, what the radio stations and chats are talking about. If there's any rumor of any disease presenting with rash, which is similar to Mpox, we are able to pick this. And on a daily basis, we scan thousands of these kinds of articles as part of our event-based systems. If we event-based surveillance system, if we pick this, we forward it to the countries to be able to confirm. Now, lastly is also now the laboratory-based surveillance system, that, when we have differential testing for patients presenting with rash, that labs are able to test, and they maintain the capacity to be able to test out this period so that we can pick this. So in other locations like Sierra Leone, they have launched very intensive community-based campaigns to get to zero, using active surveillance, moving house to house and village to village. And these are all initiatives that are geared towards being able to identify cases and ensure that we maintain a sensitive surveillance system.
And please speak a little bit more about the role of genomic and laboratory surveillance systems and the strategies that you employ in outbreak control.
Yes, thank you. So yes, we always say without lab, you are flying blind. You will not know what you're dealing with. So the lab is very, very critical. But for us to have a good system when it comes to laboratory-based surveillance or even the genomic surveillance, we have 6 elements that need to be there. You need to have the laboratory with the equipment. You need to have the trained personnel. You need to have the reagents that you use to test. You need to have a transport mechanism that gets these samples to the lab from the field where they are. You need to have the samples which are properly collected, and you need to have the patients who meet the criteria for sample collection to be tested. Now, we've been working on a four-pronged approach that targets all this. The first one in addressing the issues of equipment and reagents, we have been partnering with Africa CDC to procure and provide these to countries, and countries have also invested in those. The second issue is on capacity building, both on sample collection and packaging and transportation, as well as on testing in the lab. And currently, for instance, we have a team in Sierra Leone that have been training both on PCR testing, but also on the genomic surveillance, the genomic analysis, and the bioinformatics. We are working with the center in Institute of Pasteur Center in Dakar, for instance, to support Guinea as well, to build similar capacity. So it's a sustainable approach that we're using to be able to build capacity. And then the last one then is the issue of active surveillance, so that you can have the input into the supplies, into this laboratory system, making sure that you have intense surveillance at the community that identifies cases and refers them for testing. So this three-pronged approach is addressing those 6 core elements of ensuring that you have a functioning labs system that's able to detect and confirm cases.
How concerned should we be? I mean, because all of this, it's to no end if you are unable to treat it, particularly through vaccination. And I believe that to date, roughly 1.3 million Mpox vaccine doses have been delivered, particularly to the continent. And that is well below the estimated need of 6 to 10 million to meet response targets. So where to from here, and what can be done to alleviate this challenge?
So there are two things. One, it's evident that we are still able to control Mpox without the vaccine. We can do it with the vaccine as an adjunct, and it helps us to get there faster, but we are able to do it using the non-pharmacological interventions. And Burundi is one example that they have been able to do it. How did they do it? So you have a very good surveillance system. Intense, you investigate, identify all your cases, you do contact listing and contact follow-up, you isolate your cases, you manage them, you engage the communities, educate them on the measures to be able to take to protect themselves, on how to identify the cases and refer them for appropriate treatment, and you establish facilities where people can quickly go. So that aspect without the vaccine is able to get us to control. And where Burundi is now is an example of that. So what we have been advocating is that, yes, when we have the limited doses of vaccines, that we target the hotspots where we have intense transmission, we target high-risk groups, we target people who are at risk of developing severe disease, like people with the immunocompromised disease conditions, or people who are on chemotherapy and other drugs that lower their immunity, so that then we are able to protect that. So our focus with the vaccine at this point is on interrupting transmission. Okay. And that's what we will continue to do. Of course, advocacy for funding to produce and buy more vaccines continue, and we continue to engage both at the continental level but also at the global level.
Unfortunately, that's where we're going to have to end it. But thank you so much for your time, Dr. Patrick Otim, who is the WHO Afro Regional Manager, just speaking to us 1 year on the Mpox outbreak. How have they managed it, and what progress has been made?